Hello, my name is Dawn Schocken. I am the director for the Center for Experiential Learning and Simulation at the University of South Florida in Tampa, Florida. I have been in my role for about 20 years, and I have been working with the Society for Simulation in Healthcare for almost as long. In 2012, I became a CHSE, and I have been working with the CHSE Readiness Review Committee and Advisory Committee ever since that time. I look forward to joining you on this journey as you explore the Certified Healthcare Simulation Educator CHSE course. All of our images throughout the presentation today are royalty-free from clip art, Pixabay, or permission given by the organization. Please enjoy our course. We will be going over Domain 3 today. As you know from the exam blueprint and from your professional development worksheet, it is 40% of the certification exam. Domain 3 is including the educational principles applied to simulation. This domain focuses on moving simulation from theory and curricular development into the practice. We will begin our time together by exploring educational theories that are related specifically to simulation-based ones. Educational theories are researched ideas based upon the philosopher Plato, who pondered this question: how does an individual learn something new if the subject itself is new to them? They are essentially a set of principles to explain how a learner can acquire, retain, recall, and practically apply what they have learned. Let's look at a few that impact how we design, implement, and evaluate simulation-based activities. Let's start this exploration with the constructivist theory. The theorist Kolb and Vygotsky are two of those who believe that utilizing experiences to build on existing foundations help learners to assimilate new information. The attributes of this theory include learning a continuous process grounded in experience. It's a scaffolding learning, so we learn one step and then we build on the next step and then we build on the next step, and we allow our learners to climb the ladder to continuous experiences. We actively engage our learners in the simulation activity, giving them a role to take on, even if it's actively observing or actively participating in a debrief. We start with simple and we create our building blocks so that it gets progressively more difficult. Our next theory that we're going to explore is from Alfred Knowles, who created adult learning theory, which highlights important concepts to remember when building simulation curricula for our healthcare learners. Using adult theory when building a curriculum related to timing and the learner's need to understand how this relates to their practice. Setting up procedural sessions knowing that subject matter experts must be present and they must be trained to understand how to correctly deliver feedback, which can impact and strengthen our learning outcomes. Remember the 4 key assumptions. Adults need to know why, they need to know how, they need to know what, and they need to know when. Some examples would be creating relevant clinical scenarios that address the 4 assumptions, and allowing learners to demonstrate knowledge in simulation experiences, having them be engaged in their actual learning process. Social learning theorists create experiences because they understand that participants learn through observing, modeling, and imitating behaviors. Mastery of learning and deliberate practice understand the use of deliberate practice with assessment feedback from an expert can be used to progress a learner along a set of criteria towards proficiency. Let's explore Bandura for a moment. Bandura stated in his social learning theory that we learn by observing and we learn through role modeling. We all can think of a time in our own learning journey where we observed a mentor and tried to mimic or copy what they were doing. And our learners are doing the same thing. When they see one, they try to copy one. They try to mimic what we're doing. We are modeling their experiences. This allows the learners to watch the content experts perform specific tasks. So one would learn how to do Foley cath insertion by watching an expert to do that, perhaps studying it, reading some materials, watching more video, and then practicing. We allow our learners to watch each other so that they can give feedback to each other as they improve their technique. In mastery learning and deliberate practice, our theorists Erickson and McGeachy, their thought was to practice with intent, to practice which builds upon itself. You're allowing your learners to practice a set of clinical skills repeatedly with feedback for improvement. And the entire cycle continues until the learner has mastered that activity. We can think of things such as boot camps for residents in either nursing or medicine, where individuals practice over and over to become proficient, signed off, and allowed to move forward. Use of reflective practice means incorporating the use of thoughtful review of one's own actions to take a critical stance or attitude on one's own practice. Schoen is our reflective practice theorist. The attributes we include are reflecting during the event, reflecting after the event, and reflecting how to improve the next time we approach this event. Structure time to allow the learner to reflect while performing, after and forward thinking for the next performance. An example of this would be having a simulation of communication skills. And in that simulation, you would allow the learner to practice their history-taking skills. They would watch, you would record that for them, and they would watch what they did for the history-taking skills. And during that activity, their fellow classmates or their fellow colleagues would say, gosh, you should have remembered to ask X, or I really liked when you asked Y. It was really good. It really helped me understand what was going on with the patient. And then, after the fact, during a debrief, the learner would have a chance to watch their video and say, I forgot doing the review of systems, or I forgot to ask the past medical history. That probably would have helped me understand where we were going with the diagnoses. And then it might be an assignment for the learner to think about what they would do the next time they approached that patient with that chief complaint. That practice is listed as reflective practice. Our next theorist is David Kolb, who developed his model in the 1970s and published it in the 1980s. Much of his theory is concerned with the learner's internal cognitive processes. And since simulation educators are not always privy to each of their learning styles, it is awesome that healthcare simulation offers something for all 4 styles through experiential learning cycle. No matter how each individual best learns, they can connect with new ideas and concepts and begin to figure out what that information means to their practice via simulation. Kolb believed that by experiencing new situations, learners would then develop new concepts that could then be utilized in their own day-to-day growth. The learner would have an experience, reflect on that experience, learn from that experience, and finally, begin to try out the new learning and apply it to their situation. Learners experience a specially created simulation. A facilitator helps the learners to reflect. The learners make the connections from an earlier learned foundation, and the new concepts begin using these ideas in their practice. From mededmentor.org, we find experiential learning theory applies 4 steps to emphasize that learning is a process in which knowledge is continually shaped and evolved through experiences and is not simply static content or information. Learners can start the learning curve at any step, but must go through all 4 steps to ensure learning has occurred. Concrete experience is when the learner is involved in an experience or situation, activity, or task. Reflective observation, the learner reflects on and observes the experiences from many different perspectives. Abstract conceptualization, the learner interprets observations and creates logical conclusions, ideas, and concepts based on that observation. And active experimentation, the learner adapts and applies concepts to problem solve, make decisions, or change attitudes in future or new experiences. Only sharing to show completeness of theory and how accounts for different learning styles, Kolb identified these as diverging, assimilating, converging, and accommodating. Kolb states that the divergent learner can look at things from different perspectives. They are sensitive, they prefer to watch rather than do. Assimilating learners prefer a concise, logical approach. Ideas and concepts are more important than people. These learners require good, clear explanation rather than practical opportunity. Converging learners can solve problems and will use their learning to find solutions to practical issues. They prefer technical tasks and are less concerned with people and interpersonal aspects. People with a converging learning style are best at finding practical uses for ideas and theories. Accommodating learning style is hands-on and relies on intuition rather than logic. These people use other people's analysis and prefer to take a practical, experiential approach. They are attracted to new challenges and experiences and to carrying out plans. Now we will look at educational frameworks and relate them to simulation-based activities. Educational frameworks are different from theories in that they are a structured approach or methodology to specify the content to be learned. It organizes, plans, and reflects the level of the learner and how to guide them towards competency. In other words, frameworks encompass learning theory and look at planning, implementing, and evaluating simulation-based educational activities. Bloom's taxonomy will fit in well with the KSA verb list that is a resource for this course. Built in the late 1950s and revised in the early 2000s as a common language for educators to discuss and exchange learning and assessment approaches. This classification allows educators to see cognitive development and how lower level skills can make the foundation for higher ordered thinking. Simulation educators use Bloom's to prioritize healthcare concepts in a manner that allows for increasing comprehension and complexity as the learner progresses in the program. The whole goal of utilizing Bloom's taxonomy is to encourage higher order thought by building upon the base of lower level cognitive skills. We begin our learners with remembering, which is a knowledge base. We advance them to understand, which is an activity-based. We move them to apply, in which they're taking their learning and doing an activity such as a task or an interview with a patient. They gather the data from the patient and they analyze it to determine what the next steps of their care would be. They evaluate their analysis through lab data or imaging to assure that they're currently on the right path, and they create a management plan for their patients. An example of Bloom's taxonomy. The psychologist George Miller became concerned with the assessment of medical students. He believed that clinical assessments relied too much on testing and not enough on evaluating the actual application of the knowledge, how the learners would behave in a real situation. In 1990, he published a framework that distinguished between knowledge at the lower levels and action at the higher levels. His pyramid argues that if learners are accomplishing what we want them to accomplish, we should evaluate them in the environment in which they deliver care. Much like Bloom's, the framework helps educators understand what we are testing and whether our assessments are valid. Do they know the facts? Can they apply the knowledge? Can they demonstrate what they know? Have they integrated this into their current practice? In Miller's pyramid, we go from knows to does. And in the knows phase, we are fact gathering. In the knows how, we are interpreting and applying what we know. In the shows how, we are demonstrating what we are capable of. And in the does, we are performing this practice in our actual clinical environment. In the 1950s, Donald Kirkpatrick devised a 4-level training evaluation model as a means of appraising industrial employee training outcomes. It is now a universally recognized method of evaluating the results of training and learning programs. It assesses both formal and informal training methods and rates them against 4 levels of criteria: reaction, learning, behavior, and results. Reaction: was the training favorable, engaging, and relevant? Learning: the degree to which participants acquire the intended knowledge, skills, or confidence based on their taking part in this training. Behavior: the degree to which participants applied what they learned to their job. and results, the degree to which outcomes occur as a result of the training. We can compare Kirkpatrick to Miller in the following manner. Miller is the evaluation of the learner, while Kirkpatrick is the evaluation of the training program. In the late 1990s, David Kern presented a logical and systematic approach to curriculum development. This framework is based on the idea that all education has a goal and that medical education has a moral obligation to meet the needs of the learners, patients, and society. Let's walk the learner through each of the 6 steps and discuss the interrelated nature of this process. Please note that there are linear steps and do lead toward the final phase of evaluation, but that when amid one step, you might need information that will lead you back to ask questions from the previous step or the next step. We discuss and learn this method in a linear fashion, and yet we recognize that each step is related to all other steps. We depict this with the multi-directional arrows. In the first step, we have the problem identification and general needs assessment. We ask the question, what is the healthcare problem? What are the current approaches? What might the ideal approach be? The next step is the targeted needs assessment. What are the learners lacking in their knowledge or experience? What is the learning environment like? In the step entitled Goals and Objectives, we create broad goals and specific measurable objectives to determine whether our program is meeting its objectives. We develop educational strategies based on what the content and methodology that we are using endorse. We have an implementation of our simulation activity by obtaining support from our leadership, our educators, our subject matter experts, and our simulation program. We secure our resources. We address barriers that might be present as we run this simulation activity. We introduce the curriculum, and we administer the curriculum to the learners. The final phase is the evaluation and feedback, in which we hear from our individual learners, our team members, our faculty and preceptors and facilitators, and the program itself to complete the cycle. It may be that based on a previous program's evaluation and feedback from learners, we are beginning with a new problem which has been identified, and the cycle continues. In this section, simulation-based education is different from most types of instruction. Let's look at some of the instructional design differences we should know before we are developing our simulation-based activities. Curriculum integration is a concept that relates to pairing healthcare simulation at a certain point of the learner's curriculum to match their learner level to progress their skills and practice. Intentionally integrating simulation allows interaction with concepts and scenario variation for a wide-ranging application. This means ensuring concepts included in simulation are covered in the curricula and thus allowing for clinical application in a safe environment. A controlled environment speaks to the psychological safety and always creates repeatable learning experiences. This is accomplished when simulation experiences become standardized to ensure each learner receives the same experience. Some applications may be that the simulation could be redone for a better outcome. All learners experience the same set of standardized circumstances. Standardizing simulation-based education for all learners within the same level. We allow our learners to repeat complex scenarios again to solidify the transfer of debriefing learning to practice. The second phase of our instructional design concepts include defined outcomes, task difficulty, and feedback. In defined outcomes, we're looking at simulation design, ensuring that the learner is sure of the purpose and expectations of the experience. The goals and objectives are concise and communicated to all stakeholders through the use of SMART goals, objectives, and outcomes, with transparency for learner expectation, particularly around evaluation methodology. With task difficulty, this is a design feature that ensures the simulation activity is appropriate for the learner level. Simulations are tailored to the learner level and should not be utilized interchangeably between learner levels or disciplines. Scenarios should include different expectations and objectives based on the learner level and scope of practice. Feedback on performance needs to come from the instructor, the simulator, or the task trainer directly to the learner. This enables them to have a realistic scenario and receive feedback on their performance. Feedback should also be immediately after the simulation-based experience, allowing the learner opportunity to improve and assist in the creation of a performance improvement plan. The next in our instructional design concepts include repetitive and deliberate practice and transfer to practice. With repetitive and deliberate practice, we are taking complex skills and breaking them down into simpler tasks that can be mastered, allowing our learner to progress in a customized manner. In transfer to practice, the design concept where the educator focuses on making connections between the simulation experience and the incorporation into their clinical practice. The knowledge, skills, and attitudes are transferred into the clinical environment, and the experience in simulation mirrors what is generally occurring in clinical life. in adding a component of debriefing practice where learners can commit to a change or improvement in the clinical practice, concepts are embedded in our simulation and then in our clinical practice. The next instructional design concepts we will discuss are realism and fidelity. Realism seeks ways to incorporate levels of realism to engage the learner in the simulation activity. The simulation environment mirrors the practice environment, enhancing the learner's engagement. Through matching the realistic features of the simulation to the objectives and levels of the learner. Fidelity incorporates the elements of fidelity, including physical, psychological, functional, and conceptual in the instructional design. Incorporating these design elements that generate appropriate responses from our learners, using modalities that respond to the learner's actions. We can include moulage to generate feelings of urgency, and appropriate progression of the simulation activity that mirrors real-life clinical presentations. The next instructional design concepts are reliability and validity. The definition of reliability by Liose et al. In 2020 is the degree to which a simulation activity measures the same way each time it is used under the same conditions with the same participants, ensuring consistency of performance or measurement within a simulation activity. The design concept that ensures running of the same programmed and scripted scenario, which will result in the same outcomes. Scalesi and Hatala in 2014 defined validity as the degree to which a model or simulation accurately represents or measures what it intends to measure, ensuring the simulation activity outcomes align with the objective. In validity, designing simulation-based activities that align with the objectives, capturing ways to ensure the intended objectives are met.